Thank you very much, Matt, and good afternoon, everybody. I think there's two good reasons to talk about this topic. First of all, you're still going to see it. There's still a fair number of legacy conventional polyethylene implants around that are going to need to be managed because of the lysis that they engender. And secondly, because you're not seeing it all the time as we were maybe 10 years ago, you may not be as familiar with some of the tips and tricks and technical principles. So I'll try to cover those in the next 8 or 9 minutes. My disclosures that I receive royalties from DePuy on some hip and knee products. So I'm going to start out with a case. 67-year-old man, 15 years, status post bilateral total hip arthroplasty. He's a federal judge. And he's had the recent onset of mild bilateral hip pain. You can see his x-rays. And you might ask yourself a few questions. Does he need an operation? Maybe he needs 2 operations. If so, what would you revise and what would you revise him to? How would you manage those bone defects you see around his acetabulum and femur? And what are the main risks of surgery and how would you prevent them? So let's talk about polyethylene wear and lysis. Let's begin just by briefly talking about the indications for reoperation. They're fairly simple: severe osteolysis at presentation or notable lysis progression. And my way of thinking about this is that you ought to operate earlier if you've got a younger patient, if you believe there's a periprosthetic fracture risk, either of the pelvis or the femur, or, and this is the most common reason, if more bone loss will compromise your reconstruction options. So if you're starting to get to the point where you're going to go from a simple revision to a complex revision, it's probably time to pull the trigger. What you want to prevent is what happens on the top series of x-rays. It's a patient who had bilateral hips done elsewhere. She started having symptoms, you see where she was at the start. 6 months later, you can see the cup moving. She got referred to me, and at that time, we had to revise her. She was revised, but she already had bad bone loss, a pelvic discontinuity. We had to do a big revision on her acetabulum. She started having symptoms on her right hip. A few years later, I pulled the trigger early. We did a femoral head exchange and grafting, and she's never had to have another reoperation on the right side. So you see the benefit of intervening at the right time. Treatment basics. Change the bearing surface to a lower wear couple. That's the main point of solving the problem. If you get rid of the lysis generator, you'll be able to solve the problem effectively. And that usually means changing the person to a cross-linked polyethylene bearing. Debride and graft the osteolytic lesions. Retain well-fixed, well-functioning implants, but remove problem implants. And I'll come to that here in a minute. So, point number 1, change the bearing, get rid of the particle generator. The most common new bearing surface you will place will be a cross-linked polyethylene liner, and you see an example of us having done that here. And another example of having done that here. 78-year-old man, you can see the bad wear of his head, you can see the retroacetabular lysis. We've changed him to a cross-linked polyethylene liner, ceramic femoral head, grafted his lesions. Many times you will not have a compatible cross-linked polyethylene liner for the cup that's in situ. Don't panic. Usually you can handle this by cementing in a new cross-linked polyethylene liner from another system. I like to use a cross-linked polyethylene that I can work on the back of with a burr. I usually create a spider web pattern, so that means some X's across the back and then some circumferential circles that reduces the likelihood of the liner pulling out of the cement later or twisting in the cement. I usually do it with a 4mm burr. And I like to use a cross-linked polyethylene liner that's got a configuration where it's got a flat back of the rim, so you can actually push that rim right up against the metal and seat it firmly on the metals, because there's some that have just little tabs. You don't want to use those. And this is just an example of the patient we've treated in that manner. You can see we've gotten rid of the old polyethylene liner, we've grafted the lesions, we've cemented a new liner into this old HG2 cup successfully. Head exchange. If you do a head exchange and if you can use a ceramic head on the existing femoral component, try to do so. But use a ceramic head that allows you to use a titanium sleeve. As all of you probably know, putting a ceramic head on a used taper does carry with it a risk if you can't use a titanium sleeve. There might be some exceptions where you take the risk, but probably not most of the time. So this is kind of the classic treatment for that problem. Here you see a patient with eccentric polyethylene wear, quite a bit of retroacetabular and some femoral lysis. We've taken out the old polyethylene, we've cemented in a new cross-linked polyethylene, we've placed a ceramic head, we've grafted the lesions of the acetabulum. Those uncontained defects of the femur you can't really graft very well. You can usually graft the trochanter. Which brings me to the point of grafting the lesions. What's the best graft material? No clear data on this. I generally use allograft chips. Some people use other bone graft substitutes. If the lesions are around the periphery of the cup, they're usually accessible. You can debride them. You can graft them effectively. The point I'd make here is don't disrupt the remaining supportive pseudopods of bone that come down and have grown into the cup. And I've just put an arrow there to show you what I'm talking about. Keep those intact. They're, of course, what's going to provide the long-term cup fixation. And don't forget the ischium. The ischium often has quite a bit of lysis. You won't be able to see it as easy on the x-ray. If you work your way down there, you'll be able to feel it. You can usually scoop out the lytic lesions in that area. If the cup has holes in it, there will frequently be lysis behind the cup in the retroacetabular area that's gone through the holes. This requires being a little bit meticulous. Use small suckers, use small curettes, repetitively irrigate through the holes with a bulb-tipped syringe. You can push a lot of the osteolytic material out, and then you kind of have to, in a very meticulous way, and it's a little bit tedious, pack graft through the holes, and you can usually do a pretty good job of filling up at least most, if not all, of those osteolytic defects. Here you see an example of us having done that in that manner. And you can see we got the graft pretty well into the osteolytic lesions. This is an example of something where we've done something a little bit different. This is a woman who was in her 30s when we revised her. We did a headliner exchange. She's got a cup with holes in it. I actually took a high-speed burr and cut a triangle of metal out of the cup inside of it so I could get access to this big, huge lesion. That allowed us to do a very good job of grafting the lesion, you can see. And then we cemented a new liner in there. And I just saw her back at 15 years after surgery. She's still got this construct in place, and that graft is all healed in. A further point to make, change the cup if necessary. So don't be wedded to the idea that the cup has to stay. Sometimes the cup has to go. When will you take the cup out? Poor cup position, a cup that's such small diameter that the head size is going to be a problem for you, or a loose cup. A few examples. This patient had a vertical cup in bad polyethylene wear. I thought it was better just to take that cup out and get a new cup in there, and you can see we did so successfully. This patient had a tiny cup. That's a 22 head. There's just not room to put in a new good poly, and there's not room to put in a new good poly that's got very good stability, particularly a patient with no trochanter. So I took the cup out, and that was successful. And this is a patient who has a loose cup and lysis. Of course, that cup's got to go. One of the points about finding out whether the patient has a loose cup or not is that you have to test the cup stability very rigorously. It's not that obvious sometimes on x-ray, and it's not even that obvious when you go in there. So first of all, expose the bone implant interface very, very carefully. Make sure you're looking right at the bone implant interface, not someplace where there's some fibrous tissue in between that can hide it from you. And then vigorously toggle the cup. You can't just kind of push on it with your hands. If you can get something to screw into the cup and really toggle it, that's the best. If you don't have that instrument, grab it with a vice grip or grab it with heavy pliers and really try to move it. Make sure, 100% sure, it's not moving. If it's moving, it's got to go. And this is just an example of a cup that wasn't obviously loose, but with rigorous testing, I found it was, and we took it out and revised it. The last question you might ask yourself is, when is there too much lysis to save the cup? There's no absolutely clear answer on this. We did look up and report a couple of years ago the results of polyethylene liner exchange and femoral head exchange in the situation of lysis, and it does give you a little bit of guidance. What we learned from that is if there's lysis in all three zones of the cup, the long-term loosening rate is roughly 23%. It probably depends a little bit on cup design. And if the lysis makes up a contiguous area of more than half the cup interface, the long-term loosening rate was about 40%. So that gives you some hard data you can use to talk to the patient about what the absolute risk is of the procedure failing if you save the cup. My personal approach to this is that in most cases, I think it's worth trying to retain the cup, even with the data I showed you. For sure, if the lysis is modest, it's worth retaining it. As it gets more severe, you have to think about it harder. In most cases, except the most severe ones, I'll try to save the cup. I'll explain the logic to the patient that it's a smaller surgery, you don't lose fixation, we'll graft for the future, and if at some point that cup fails, we will come back and do something. There are rare situations when you take the cup out, but remember, if you take the cup out in a situation with terrible lysis, that's your worst scenario in terms of getting new cup fixation. Last point I'll make is prevent dislocation. Every series that looks at this recognizes that dislocation is the most common complication of this operation. In the group that we reported on, it was a risk of 16% over about 5 to 10 years. Strategies to prevent dislocation: use the right operative approach, and then deal with head diameter, leg length, and post-op management. I'll bring just a couple comments about each. First, choose the optimal operative approach. And by that I mean look at the cup anteversion. Get a good lateral radiograph of the hip. Understand, does that cup got little anteversion or a lot of anteversion? And my approach to this, if it's got a lot of anteversion, I'll go posterior. If it's got very little anteversion, I'll try to keep the posterior structures intact and use I would use an anterolateral approach, but somebody adept at the direct anterior could use a DA approach. So here, a low anteversion cup, I've done an anterolateral approach, the patient remains stable. Here, a patient with higher anteversion, I showed you her x-rays earlier, we did a posterior approach. Upsize the femoral head diameter when possible. Of course, it provides better hip stability. I won't belabor that point. This patient started out with a 26 millimeter head, new cemented liner in place. We went up to 36 millimeter diameter head. Usually you want to plan to gain a little bit of length in these patients. Gain it somehow so you maintain hip stability, either using a longer neck length, which is my preference because it doesn't give you an eccentric load on the acetabulum, but if absolutely required, an offset liner, but remember that that does create eccentric loads on the acetabulum. So here you see we've gained neck length and maintained hip stability. Here we were out of neck length. You see that skirted head already present on the x-ray on your left, so we had to gain the length and the stability by using a lateralized liner, which is not my preference. Post-operatively, I think most of these patients, it's worth bracing them. Probably reduces the risk of an early dislocation, which you know is your biggest risk. Now finally, back to the opening case. The 67-year-old federal judge. I told him he needed an operation. I told him he needed 2 operations. He needed 1 on each hip. We sequentially, over the course of about 6 months, did a cross-link polyethylene liner on his right hip. We used an elevated rim liner. We used a posterior approach because he had sort of an intermediate amount of acetabular anteversion. There were no ceramic heads available for these implants, so we used metal heads. I told him that going into it, and we grafted him. You can see the ultimate result. Stable hips, done a reasonable job of getting graft into the lesions, and hopefully low wear bearing surfaces. So I'll conclude by saying you will still see and encounter polyethylene wear and lysis. A limited head and liner exchange is usually possible. The go-to bearing, if possible, will be cross-linked polyethylene in a ceramic head with a sleeve. Do your best to graft the lesions effectively. Try to avoid instability. Thank you very much for your attention.